Dear student, I am Dr. Prakash Mungli, Professor of Biochemistry. So in this lipoprotein metabolism lecture, I will be going over HDL metabolism and applied clinical aspects. So let's get into the details. Now the HDL, which is a high density lipoprotein, so it is synthesized in the liver, intestine and also by budding of Apo A-I apolipoprotein from the HDL in the circulation. So overall, HDL is synthesized in two major organs. One is in the liver, other is in the intestine. And also it can be synthesized in the circulation using available Apo A-I apolipoprotein. Now, nascent HDL, which is coming out of liver and intestine, so it is going to accumulate a phospholipid and cholesterol esters from cells lining the blood vessels. Now, what happens is LCAT enzyme, that is Lecithin Cholesteryl Ester Transferase enzyme, it is going to convert the cholesterol that is coming out of the peripheral cells through the ABC-A1 transporters and convert that into HDL3. Now HDL3 will be converted into HDL2 by an enzyme called Cholesteryl Ester Transfer Protein. And then this HDL2 molecule, which is rich in both cholesterol ester and 𝗏𝐻DL, it will be taken up by scavenger receptor B1 in the liver and contents will be offloaded into the liver. Or hepatic lipase over the hepatocyte membrane, it will help to degrade 𝗏𝐻DL present in the HDL2 molecule and convert that into HDL3 and release into the circulation. Now let me explain you how exactly a nascent discoidal HDL will be converted into HDL3 and later into HDL2 and how it will be taken up by the liver to be offloading all the content that is coming from HDL from the peripheral circulation. Now there is something called as reverse cholesterol transport mechanism that you must remember here in order to understand the metabolism of HDL cholesterol. Now one of the function of HDL cholesterol is to remove excess cholesterol from the peripheral tissues and bring it back to the liver. And that means the reverse journey of cholesterol from the peripheral tissues back to the liver is referred as reverse cholesterol transport mechanism, and this is done by high density lipoprotein. And this is a particularly beneficial for vascular tissue because accumulation of that excess cholesterol in the vascular tissue may initiate atherosclerosis process leading to hardening of the blood vessel. Now there are ABC category of transporter, that is ATP binding cassette transporters, which will help in pumping of excess cholesterol to the HDL molecule to convert that into cholesterol ester and transport it back to the liver. And those transporters that will do the efflux of cholesterol out of the tissue which accumulates that cholesterol in the peripheral tissue is ABC-A1 transporter, ABC-G1 transporter and SRB1 transporter. Now the ATP binding cassette transporters, that is ABC-A1, ABC-G1 and SRB1, these are ATP dependent cassette transporters which will do efflux of cholesterol out of the cell. Now the LCAT, which is present over the surface of the HDL, is going to take this cholesterol and convert that into cholesterol ester and put it into the interior core of the HDL, and that's how HDL3 is made. Now since the HDL3 is rich in cholesterol ester, the cholesterol ester transfer protein that we have seen in VLDL metabolism, what it does, it is going to exchange this cholesterol which is there in the HDL3 for 𝗏𝐻DL with VLDL, IDL and LDL molecule, thereby HDL3 is converted to HDL2. Now the HDL2 is taken up by scavenger receptor B1 over the hepatocyte surface, thereby moving the cholesterol ester into the hepatocyte. And also the hepatic lipase enzyme, which is present over the surface of hepatocyte, it will degrade a triacylglycerol present in the HDL2 molecule and release HDL3 into the circulation. Now, this is how a reverse cholesterol transport mechanism will be going on, and this is how HDL metabolism is going on in our circulation. Now, in this figure, let me explain you in detail using the figure how HDL metabolism is going on in the circulation. Now, let's begin with the synthesis of HDL. Now, the HDL, as I said before, is synthesized by liver, it is synthesized by the intestine, and also it is synthesized in the circulation. Way they are synthesized is liver has got an ability to make Apo A1, small intestine has got an ability to make Apo A1, and also Apo A1s that are budding off from the previously circulating HDLs in the circulation when they are kind of undergoing degradation. So those Apo A1s can also be used. So how they will be helping in the synthesis of HDL. So the Apo A1 is going to recruit other apolipoproteins in the circulation. Majority of them are coming from the liver, and also the loading of phospholipid and cholesterol ester from the peripheral tissues, from the phospholipid layer, right? So all that will make a discoidal mass called as discoidal HDL, which is a nascent HDL. Discoidal nascent HDL. And when this collection of phospholipid, cholesterol, Apo A1, LCAT, CETP, peroxanase, other apolipoproteins, all these collection of molecules as it is circulating in the blood vessel, as they go through the capillary, as they go on the capillary endothelium. So some of the tissues which are beneath that capillary endothelium, whenever they have excess cholesterol, that excess cholesterol is effluxed out of the tissue into the circulation, especially in association with ABCA1 with the LCAT enzyme. Okay, so let me show you that. Here is the tissue that is shown, where I will write this tissue as excess cholesterol here, especially cholesterol ester and all that. So basically the cholesterol. So the excess cholesterol in the tissue, it is pumped out of the out of this tissue through 3 types of ATP binding cassette transporters, and that is ABCA1, ABCG1 and SRB1. Now the ABCA1, ABCB1 and SRB1 transporters, what they will do is, so they are going to transport the excess cholesterol present in the peripheral tissues into the blood circulation, especially when they come in contact with Apo A1 that is in association with LCAT enzyme, which is basically part of nascent discoidal HDL. So with LCAT and Apo A1, this cholesterol, it will be converted into cholesterol ester by the LCAT enzyme, because LCAT is lecithin cholesterol acyl transferase. Lecithin cholesterol acyl transferase enzyme, it is activated by Apo A1. Apo A1 is an activator of LCAT enzyme. So in association with Apo A1 and LCAT, the cholesterol that is coming out of the peripheral tissue will be converted into cholesterol ester, and it will be stored in the interior core of this nascent discoidal HDL. And as more and more cholesterol ester is loaded into the nascent discoidal HDL by the continued action of ABCA1, SRB1, ABCG1 along with Apo A1 activating LCAT, and LCAT is converting cholesterol into cholesterol ester. All this is continuously going on, and the molecule is now becoming big. Nascent discoidal HDL, which is discoidal in disc-like shape, it is now becoming spherical because of the loading of cholesterol ester. Mainly, it is the cholesterol ester that is increasing here in HDL3 molecule. So because of this increase in the cholesterol ester, so the interior core of this molecule is kind of becoming big, Okay, so I'm going to retain only cholesterol ester here just to make sure that we are highlighting the importance of that cholesterol ester, which is coming from LCAT enzyme action. So more and more cholesterol is it is stored in the interior core of this HDL3 molecule. So HDL3 is super rich in cholesterol ester now. So what happens? Now the LCAT continuously work with the ABC-A1 SRB1 and ABC-G1 along with Apo A-I, which is an activator of LCAT. More and more cholesterol ester is loaded. We have HDL3. Now this cholesterol ester present in HDL3, it is exchanged by an enzyme called Cholesteryl Ester Transfer Protein. Briefly, we have seen this enzyme in VLDL metabolism. What this Cholesteryl Ester Transfer Protein does? That is CETP. Let me write it down here. CETP. CETP is Cholesterol Ester Transfer Protein. Cholesterol ester transfer protein, what it does, it is going to exchange cholesterol ester present in HDL3. HDL3 is going to give cholesterol ester to VLDL, IDL and LDL. And in return, these VLDL, IDL, LDLs, they will give triacylglycerol to HDL3. So this kind of exchange is going on between HDL3 and VLDL, IDL, LDL, where HDL3 is giving them cholesterol ester, VLDL, IDL, LDL will give them triacylglycerol. So eventually what is happening here, VLDL converting into IDL, IDL converting into LDL, so they all become rich in cholesterol ester and losing triacylglycerol, and whereas HDL3 is gaining triacylglycerol. But note that HDL3 generally don't lose cholesterol ester, although it is given out. But the thing is, LCAT enzyme continue to work. This LCAT enzyme, as I am showing here, it is continue to bring cholesterol ester coming out of the cell through ABC-A1, SRB1 and ABC-G1 transporter, and it is continued to be loaded into HDL3 molecule, and eventually HDL3 will be converted into HDL2. Okay, now HDL2 molecule, as I am showing, so it is rich in triacylglycerol and also it is rich in cholesterol ester. So in fact, HDL2 molecule is much bigger than HDL3 because this HDL2, it is super rich in triacylglycerol and also cholesterol ester. Now I have remodified this particular figure and made it a big molecule. Now HDL2 is a bigger molecule than HDL3. HDL3 is a relatively smaller molecule, right? Because it is rich in cholesterol ester only. Now HDL2 has both the things. It has triacylglycerol, which is because of the exchange between VLDL, IDL, LDL for cholesterol ester with HDL3, and also continued action of LCAT enzyme bringing more and more cholesterol ester from the peripheral tissues. Now HDL2 has both the molecules. Tags are there and cholesterol ester are there. Now what happened to HDL2? HDL2 can go back to the liver and offload its content. So that is done through SRB1 receptor. This SRB1 receptor, it's a scavenger receptor where it is going to interact with HDL3 molecule and content is offloaded into the liver. Basically cholesterol, cholesterol ester, phospholipid and triacylglycerol, all that is offloaded into the liver, and that's how HDL2 is removed from the circulation. Now another fate of this HDL2 can be, that's one fate of HDL2, interacting with SRB1 receptor. Now the other fate of HDL2 is HDL2 can interact with hepatic lipase enzyme, and by interacting with hepatic lipase enzyme, only triacylglycerol is offloaded into the liver, tags offloaded into the liver as free fatty acids and glycerol, because hepatic lipase, it is going to degrade a triacylglycerol present in HDL2 into free fatty acid and glycerol molecule. So free fatty acid and glycerol entering into the liver, and the rest of the molecule will be released back into the circulation as HDL3. So overall, hepatic lipase is going to convert HDL2 into HDL3, whereas SRB1, it takes HDL2 into the liver. Okay, so this is how HDL2 will meet with its fate. One is it is offloading all the contents to the liver. Other is it will just offload only triacylglycerol and come back into the circulation as HDL3. Okay, so this is how the excess cholesterol that was present in the peripheral tissue, excess cholesterol present in the peripheral tissue is carried to the liver with the help of HDL. And this movement of excess cholesterol from the extrahepatic tissue to the hepatic tissue is called as reverse cholesterol transport mechanism, and that is done through HDL molecule. And so many molecules are helping in this process, starting from the efflux of cholesterol from the peripheral tissues through ABCA1, ABCG1, SRB1, which are pulling out excess cholesterol into the circulation in association with Apo A-I, LCAT, where LCAT is activated, converting cholesterol into cholesterol ester, and the fatty acid for this conversion of cholesterol into cholesterol ester will come from a phospholipid called lecithin. Lecithin is the one that will give fatty acid to LCAT to make cholesterol into cholesterol ester, and lecithin in turn will be converted into lysolecithin. Let me write it here. So lecithin is the donor of fatty acid in the conversion of cholesterol into cholesterol ester, while lecithin is converted into lysolecithin, and this is the reaction catalyzed by LCAT enzyme. So lysolecithin is one of the co-product in this reaction, because lecithin is part of our cell membrane and it is used and releasing lysolecithin there, while cholesterol is converted to cholesterol ester, and that's how LCAT is going to convert cholesterol into cholesterol ester and store it in the interior core of HDL3 molecule. And then HDL3 exchanges its cholesterol ester for triacylglycerol with VLDL, IDL, LDL. This is done by Cholesteryl Ester Transfer Protein, and that's how, with the continued action of LCAT and CETP, HDL3 will be converted to HDL2, and HDL2 is taken up by the liver through SRB1 receptor, or HDL2 simply interacting with hepatic lipase. It is just offloading triglycerides into the liver and converting back, getting back into the circulation as HDL3. So this is what is the metabolism of HDL. Now let's look at a disease called Tangier disease. Now the Tangier disease, it is an autosomal codominant disease due to a mutation in an enzyme. Now the Tangier disease, it is an autosomal codominant disease due to mutation in the gene that is coding for ABCA1 transporter. You know the role of ABCA1 transporter. ABCA1 transporter, it is causing efflux of excess cholesterol from the peripheral tissues to nascent discoidal HDL, so that cholesterol can be converted into cholesterol ester. So this kind of efflux of excess cholesterol from cells, including the blood vessels, will be defective in this particular disease. And because of this, what will happen? Nascent discoidal conversion into HDL3 is now not going on, or it will be decreased, because for that you need ABCA1 transporter to pump that excess cholesterol to get into the HDL. Now the development of nascent discoidal HDL into HDL3 will be down, and that is why patients will show low plasma HDL levels, which is usually less than 5 mg per deciliter. Normal HDL is 40 to 60 mg per deciliter. Remember that. So extremely low circulating levels of Apo A1 will be seen, and patients will show accumulation of cholesterol in the reticuloendothelial system. Hepatosplenomegaly can be seen, and more importantly, patient will show a pathognomically enlarged grayish yellow or orange colored tonsils. And that's one of the signs that we see in Tangier disease. Remember, Tangier disease patient will show orange colored tonsil. Along with these signs, patient will show intermittent peripheral neuropathy, which is referred as mononeuritis multiplex. And also patient may show sphingomyelin-like neurological disorders. And patients may show increased risk of premature atherosclerosis in Tangier disease. Coming to another disorder that is associated with HDL metabolism is familial lecithin cholesterol acyl transferase deficiency, simply referred as LCAT deficiency. And the LCAT deficiency, it follows autosomal recessive inheritance pattern. There can be two types of LCAT deficiency. One is a complete LCAT deficiency, other is incomplete or partial LCAT deficiency. Complete LCAT deficiency is called as classic LCAT deficiency, and partial LCAT deficiency is sometimes referred as fish eye disease. Now in this particular disorder where LCAT activity is decreased, and know that LCAT, it is participating in the conversion of cholesterol into cholesterol ester, especially the one that is coming out of the peripheral tissue. So LCAT converts cholesterol into cholesterol ester. Now because of the deficiency of LCAT is deficient, that's why conversion of cholesterol into cholesterol ester decreases. So there will be decrease in the cholesterol ester in HDL. That means conversion of discoidal HDL into HDL3 is decreased. So there will be decrease in HDL3 formation, and there will be increase in the free cholesterol in the blood, and also conversion of cholesterol into cholesterol ester. In this process, lecithin is normally converted into lecithin, and that is also not going on here. So lecithin simply accumulates. So overall, because of LCAT deficiency, so there will be lack of cholesterol esterification will be seen here, which leads to impaired formation of mature HDL molecule. Now the plasma concentration of cholesterol esters and lecithin are low because cholesterol ester formation needs LCAT activity, lecithin formation needs LCAT activity. Both of them will be decreased, whereas free cholesterol will be elevated in the plasma. Now because of this, when HDL3 is not formed, HDL3 is necessary for CETP action, because HDL3 is the one that will exchange cholesterol ester for triacylglycerol with VLDL, IDL and LDL, and that is not going on here. And because of this, there will be a abnormal composition of VLDL, IDL and LDL, and that is what is shown here. See the LDL, which is the type of LDL that we are seeing in LCAT deficiency, called as lipoprotein X, and this LDL will have lower levels of cholesterol ester, and that's why it is called as lipoprotein X. And VLDL also has lower level of cholesterol ester content, so it is called as beta VLDL. Instead of normal is pre-beta, VLDL is pre-beta, here it is called as beta VLDL. So presence of beta VLDL, presence of lipoprotein X, and decreased cholesterol ester, decreased lecithin, increase in free cholesterol levels, and decrease in HDL levels in the blood, they all will give clue towards familial lecithin cholesterol acyl transferase deficiency. Now, what are the signs and symptoms we see here? Other than the laboratory features that I have explained to you in the previous slide, so the patient will show progressive corneal opacification and very low plasma levels of HDLs, very variable hypertriacylglycerolemia can be seen as a laboratory feature. And these features will be same in partial LCAT deficiency. There is no other clinical sequel is seen other than what has been explained so far. Whereas in complete absence of LCAT or complete LCAT deficiency, additionally patient will show hemolytic anemia and also a progressive renal insufficiency, which will eventually lead to end stage renal disease. Okay, so these are the additional signs that you see in complete LCAT deficiency. Basically, absence of LCAT leading to classic LCAT deficiency, right? So complete LCAT deficiency or absence of LCAT is a much more severe condition than the partial LCAT deficiency, that is referred as fish eye disease. Okay, so these are all these are the two disorders that are associated with HDL metabolism. Now our next disease that is given here is familial alpha lipoprotein deficiency. Alpha lipoprotein is HDL, and HDL deficiency here that includes Tangier disease, fish eye disease, and Apo A-I deficiency. Note that Tangier disease is because of mutation in a gene coding for ABCA1 transporter. We have seen that just now. And fish eye disease is because of decreased activity of LCAT enzyme. And Apo A1 deficiency will also lead to decreased activity of LCAT enzyme. So overall, HDL formation will be decreased, leading to very low or absence HDL here. Alright, so our next disorder is hyperlipoproteinemia category. In that we have familial lipoprotein lipase deficiency, which is type 1 hyperlipoproteinemia according to Fredrickson's classification. Now, here what happens, because of the decreased activity of lipoprotein lipase, so patient will show severe hypertriacylglycerolemia. This can be because of lower activity of LPL or defective Apo C-II, which is an activator of LPL. So patient will show slow clearance of chylomicrons and VLDL, and also patient will show abdominal pain, pancreatitis, all those features. Coming with the next hyperlipoproteinemia is type 2A hyperlipoproteinemia, that is familial hypercholesterolemia, which is hyperlipoproteinemia type 2A as per the Fredrickson's classification. The defect is LDL receptor mutation, and the most common LDL receptor mutation is seen in ligand binding domain and exon number 4. So of course elevated levels of LDL will be there in the circulation, giving rise to hypercholesterolemia and atherosclerosis in early stages. Okay, basically if it is a homozygote condition, atherosclerosis will appear earlier on, and death usually occurs before 20 years of age. And if it is a heterozygote condition, the severity will be less compared to homozygote. Now coming to familial type 3 hyperlipoproteinemia. This familial type 3 hyperlipoproteinemia is also called as broad beta disease or remnant removal disease, also referred as familial dis beta lipoproteinemia. And this is because of slow clearance of remnants, lipoprotein remnants, and the lipoprotein remnants are chylomicron remnant, and also IDL. IDL and chylomicron remnants are the lipoprotein remnants, and the defect here will be the Apo E. Apo E will be defective because Apo E is the one that is recognized by LRP1 receptor, that is LDL receptor like protein 1. It is referred as a remnant receptor, and Apo E present over chylomicron remnant and IDL is recognized, and it is taken up by the liver. So if there is a defect in Apo E, so recognition by LRP1 will be defective, and that means chylomicron remnants and IDLs are not taken up by the liver, they just stay back in the circulation, so leading to elevation of remnants in the circulation. This type of disease is referred as remnant removal disease, which is also called as familial dis beta lipoproteinemia. Other name for that is familial type 3 hyperlipoproteinemia. Okay, so patients lack isoforms of E3 and E4 and have only E2 here, which does not react with the E receptor. that is the remnant receptor. Okay, so now let's move on to see our next disease in this particular table is familial hypertriacylglycerolemia. Now the familial hypertriacylglycerolemia is referred as type 4 hyperlipoproteinemia, and this is because of overproduction of VLDL, often associated with glucose intolerance and hyperinsulinemia. That means excess carbohydrate intake giving rise to hyperglycemia, and this hyperglycemia, if accompanied by hyperinsulinemia, which is seen during obesity, overweight, glucose intolerance, diabetes mellitus, all that will give rise to this condition, that is familial hypertriacylglycerolemia, and that is grouped under type 4 hyperlipoproteinemia as per Fredrickson's classification here. So the cholesterol levels will rise with the VLDL concentration. LDL and HDL tend to be subnormal. This type of pattern is commonly associated with coronary heart disease, type 2 diabetes mellitus, obesity, alcoholism, and administration of progestational hormone. And in fact, familial hypertriacylglycerolemia is the common hyperlipoproteinemia associated with the metabolic disorders, especially with the type 2 diabetes mellitus. And then the other disease mentioned here is familial hyperalpha lipoproteinemia, where there is increase in HDL concentration. It's a very rare condition, although it is a beneficial thing for health and longevity. Hepatic lipase deficiency can be seen, where there will be decrease in the activity of hepatic lipase, leading to accumulation of triacylglycerol rich HDL, 2 molecule, and also IDLs are not undergoing metabolism. Familial lecithin cholesterol acyltransferase deficiency, we have seen that in the previous slide. There can be partial deficiency or complete absence of enzyme, giving rise to low HDL levels and increased levels of abnormal LDLs and VLDLs. Okay, so these are all the primary disorders associated with plasma lipoproteins, which are grouped under hypolipoproteinemias and hyperlipoproteinemias. In hypolipoproteinemias, we have A beta lipoproteinemia, Tangier disease, fish eye disease, Apo A-I deficiency. In hyperlipoproteinemias, so we have type 1 hyperlipoproteinemia, which is familial lipoprotein lipase deficiency. Type 2A hyperlipoproteinemia is familial hypercholesterolemia. Type 3 hyperlipoproteinemia is referred as remnant removal disease or familial beta lipoproteinemia, and type 4 familial hyperlipoproteinemia is familial hypertriacylglycerolemia, which is a lifestyle associated disorder. And then we have familial hyperalpha lipoproteinemia, hepatic lipase deficiency, and LCAT deficiency. So this is all about HDL metabolism, and we have seen how HDL is synthesized, how HDL is metabolized, and how HDL is participating in reverse cholesterol transport mechanism, and the disorders associated with HDL metabolism we have seen, and along with that we have revised briefly all the diseases which are related with hypolipoproteinemia and hyperlipoproteinemia. That's all about lipoprotein metabolism. I hope this lipoprotein metabolism lecture series has helped you in understanding this very important concept of lipoprotein metabolism. Thank you.